Welcome back to ADHD, Anxiety, and More, Child Mental Health for Pediatrics. I'm your host, Dr. Elise Fallucco, child psychiatrist and mom. So we're continuing our series on non-stimulant treatment for ADHD. Today we're going to talk about another class of meds called NRIs, or Norepinephrine Reuptake Inhibitors. And that includes Viloxazine ER, which is Qelbree, and also an older med called Atomoxetine, or Strattera. We're going to talk about when these meds can be helpful in your toolbox, which kids and teens they work really well for, and what you should consider when you're prescribing them. So the cases when these would be good are for kids who've just had a poor response to stimulants, or for families who are just vehemently opposed to using stimulant meds and don't like the idea of controlled substances. Non-stimulant meds are also really good for teens where you're worried about diversion or misuse. But I think probably the most common use for these type of non-stimulant meds are really when kids have failed a couple of trials of stimulants and you're just looking for something new. So let's talk about a case so that we can understand how this plays out in practice. Sophie is a 12-year-old girl in 7th grade. She's always been really bright and conscientious, hardworking, and a little bit people-pleasing. But over the past 2 years, since starting middle school, her executive function demands have outpaced her ability to compensate. So she's forgetting assignments, she's losing materials, she's just losing points across a number of classes because it's hard to stay organized and remember what is due which day for which class. She takes hours to complete her homework and needs repeated prompting and one-on-one attention from one of her parents. Teachers say that she seems like she's distracted in class and sort of in her own world, no behavior problems, no hyperactivity. She does have some anxiety symptoms. She worries a lot about getting good grades. And as she's watched her grades fall, there's been this snowball effect. So as her ADHD symptoms have impacted her ability to function as well as she wants in school, that kind of ramps up her anxiety symptoms. And then the more anxious she is, sometimes the more difficult it is for her to pay attention in class. The ADHD contributes to the anxiety, which in turn affects academic performance, which in turn makes her feel even more anxious. So we've got to get in and break the cycle. You diagnose her with ADHD, predominantly inattentive type, if we're being fancy, and you suspect that there's some possible anxiety as well. You thought about checking a scared to evaluate for anxiety, but you didn't, but you're going to make a note in the future to do that because that would have been, in hindsight, a really good thing to do. But right now, you're worried about the ADHD and how to treat it. So let's say you started a methylphenidate preparation. Wink, wink. I like that option because you know how I feel about starting with methylphenidates. Unfortunately, she developed some appetite suppression on the methylphenidate, and it really hurt her stomach, and you couldn't get to a dose that caused enough of a positive impact without running into these side effects. So you decide to shift and move to an amphetamine type medication. And again, you ran into side effects. The amphetamine made her more irritable and a little bit more anxious within really the first couple of days of trying it. And she felt like she was just not herself. So to summarize, now you've got this 12-year-old girl with ADHD that's impacting her grades and contributing to some anxiety symptoms. You've tried 2 stimulant trials, neither of which was very well tolerated or effective. So what do you do? Now, many of you have heard me talk about this before. After you fail a methylphenidate and amphetamine, sometimes I'll talk to the family about trying a dexmethylphenidate, so a product in sort of the Focalin family. But this family is fed up, and that sometimes happens in clinical practice too. And they've said, look, we've tried 2 of these stimulants. They have not gone well. We want to try something different. Is there a non-stimulant option? Aha. So here we can begin to think about things like the Norepinephrine Reuptake Inhibitors, or NRIs. And in clinical practice, I generally prefer Viloxazine ER, also known as Qelbree. It's sort of my favorite NRI-like medication, although there is another NRI medication that's a little bit older called Atomoxetine or Strattera. Before we dive into both of those, I just want to give you my rationale and why my clinical preference is for Viloxazine or Qelbree. Viloxazine has FDA approval for kids 6 and older for ADHD. And if you're comparing these 2 NRIs, Viloxazine tends to work more quickly. We have studies that show you can begin to see an improvement within the first week or 2 with Viloxazine, whereas with Strattera, sometimes you have to wait 4 to 6 weeks to begin to see effects. And I know what you're thinking. 1 to 2 weeks does not sound very fast, especially when you're comparing to stimulants where you can know, honestly, within the first day or couple of days whether this is going to be an effective medication. But these are a different type of medication. And in some ways, you have to think about them almost like we think about SSRIs, where these are meds you have to take daily. They build up in your system. They cause changes. And we don't begin to see a maximum response till about 4 to 6 weeks. The other reason why I tend to like Viloxazine better than Atomoxetine is because it tends to be better tolerated. We have some evidence that suggests that fewer people stop Viloxazine because of side effects relative to Atomoxetine, which tends to have tolerability problems with some GI upset, decreased appetite, and sleepiness. So I've already talked about 2 reasons why I like Viloxazine better than Atomoxetine. The third reason why my first choice is not Atomoxetine is that there's significant genetic variability in how quickly people metabolize Atomoxetine. So that means that people who are slow or poor metabolizers can develop side effects on really low doses, whereas ultra-rapid metabolizers may need really high doses to achieve a therapeutic response. So bottom line, it's just going to be harder for us to find the ideal dose of Atomoxetine. The guidelines say that you start at the lowest dose and target up to a weight-based dose of about 1.2 to 1.4 milligrams per kilogram per day. But keep in mind that there is this variability. While Atomoxetine at one point was marketed as a go-to option for kids with ADHD and anxiety, what the data actually shows is that Atomoxetine doesn't worsen anxiety, but it's certainly not as effective at treating anxiety as our first-line treatments like CBT and SSRIs. Unfortunately, it's not a 2-for-1. It doesn't actually effectively tackle both anxiety and ADHD. Okay, so we've talked about when to use NRIs and why I prefer Viloxazine over Atomoxetine. And side note, I haven't said this recently, but I hope you know I have no ties to pharma. You can tell there's no sponsoring, advertisements, or anything else. This is meant to be clinically relevant evidence that is free from bias or sponsorship or conflicts of interest. Back to the case. So I'm sure you're wondering, what are we doing with this 12-year-old girl with ADHD and a little bit of anxiety who's failed 2 stimulant trials, and the family does not want to keep playing the stimulant game? So in this case, it might not be a bad option to try Qelbree, aka Viloxazine ER. So we start her on Viloxazine ER 200 milligrams daily. About a week or so later, mom says she's starting her homework without me having to prompt her. The teachers are saying she's paying better attention, and she says she's starting to feel less scattered, which is a really good sign. She's still having some difficulties, and so you make the decision to increase from 200 to 400 milligrams. And when you see her back for her 4-week follow-up, she has rave reviews. She's turning in assignments. She's more locked in class. Her grades have already started to improve. She's tolerating it well, maybe a little bit of sleepiness initially, but she is feeling great now. No GI side effects, no other side effects. Her anxiety is perhaps a little bit less because she's not as worried about her grades now that they're doing better. But most importantly, her anxiety has not gotten worse, and her mood has not changed for the worse, which is what we had seen with some of the stimulant meds. So you decide to keep her on 400 milligrams and follow her back up in a month. Okay, to recap our episode, clinical pearl number 1, NRIs, or norepinephrine reuptake inhibitors, can be a good option in kids who have not tolerated stimulants or failed stimulant trials. While they're not as effective as stimulants are as a whole, many kids tend to respond well to them. The major downside of NRIs is how long it takes to see an effect. For families who've already tried one med or a couple of meds and are getting frustrated about treatment, it's a really hard sell to say, let's start a medicine, but you're not really going to see a response for another month. That takes a lot of patience, and so I think that may be one notable drawback of these meds. And when it comes to deciding whether you're going to choose Viloxazine ER, which is Qelbree, or Atomoxetine, which is Strattera, things to keep in mind are that with Viloxazine or Qelbree, dosing is more straightforward. You tend to see an effect within the first 1 to 2 weeks. And in general, it tends to be better tolerated than Atomoxetine or Strattera. All right. So please keep sending your questions, your thoughts, your ideas for clinical cases. And if you want to learn more about ADHD and get CME credit and access to a bunch of downloadable ADHD resources, make sure to check out our CME course, Cracking the ADHD Code: Essentials for Pediatric Clinicians. See you next time.